Welcome to my new series, Clinical Case Scenario. In this series, I will attempt to discuss each day one clinical case. And these are real cases, and I will discuss how to go about coming to a diagnosis and management. And at the end of the discussion, I shall also give you some questions and also some tips or information on the subject concerned. Okay, let's start with our first case scenario 1. The history of the patient. Okay, here the patient is a 41-year-old female who presented with right hypochondrial pain for 1 week. It was a dull pain, initially mild but increased over the next few days before admission. This was accompanied by yellowness of the eyes, dark urine, and generalized itchiness over the whole body. She had low-grade fever, but no urinary and bowel symptoms. She also complained of mild, vague epigastric pain for the past 3 weeks before her admission. She has been feeling unwell with loss of appetite and nausea, but no vomiting. She had been on oral contraceptives for 2 years. She had an ovarian cystectomy 2 years ago and no other surgeries before. She is not a diabetic or hypertensive. On examination, she had a temperature of 38 degrees Celsius and was deeply jaundiced and no pallor. The heart rate was 96 per minute and the blood pressure 100/20 by 72 millimeters of mercury. The abdomen was mildly tender in the right hypochondrium and epigastric regions. No guarding, and the rest of the abdomen was soft and non-tender. The liver and gallbladder were not palpable and no masses were palpable. Okay, now these are the questions which I pose to you. Please go through the history and the physical examination and answer these questions 1 to 5 before looking at the answers that I'm about to give you in the discussion later. Now we come to the analysis of the case. Okay, this is a same thing that I showed you just now, but here I've highlighted the important points in the history and the physical examination in blue. Okay, so the important things in the history, the patient is a female, 41 years old. The 1 week history of right hypochondrial pain. The pain, dull ache in nature, initially mild but increased over the period days before the admission. This was accompanied by yellowness of the skin, eyes, dark urine, and generalized itchiness. She had also fever, okay, but no urinary and bowel symptoms. She had epigastric pain for the past 3 weeks and has not been feeling well since then. She's been on oral contraceptive for the past 2 years and had an ovarian cystectomy 2 years ago. Okay. And in the examination, she had 38 degrees Celsius, deeply jaundiced, and tachycardic with a 96 beats per minute, but she did not have any hypotension. There is tenderness mildly in the right hypochondrium and epigastric region. There's no guarding, or the rest of the abdomen was soft, liver, spleen, not, and gallbladder not palpable. Okay, so from the history, you have come to this. These are the features that you have got: yellowness of the eyes, dark urine, and itchiness. Epigastric pain for 3 weeks, feeling unwell with loss of appetite, and on is known to have been on contraceptive. And these are the relevant negative symptoms. No urinary or bowel symptoms, no medical illness. What I want to know further is whether chills and rigors is associated with the fever. Okay, there's no mention of this, which we want to know from the patient. And also there's no vomiting of any sort. Okay, so this is also not mentioned in the end. In fact, there is no vomiting. Okay. So from the history, we come to with this history, with all these features which I've mentioned just now, of obstructive jaundice with right hypochondrial pain in a female patient aged 41. Okay, these are the likely causes. Acute cholecystitis, CBD stone and cholecystitis, acute pancreatitis, cholestatic jaundice due to the contraceptive, hepatitis, bile duct strictures, periampullary carcinoma, and carcinoma head of the pancreas. These last two are highly unlikely due to the acute onset of 3 weeks and the patient being young. Now, in the examination, the issues that we mentioned were fever, deeply jaundice, and mild tenderness right hypochondrium. Okay, and the relative negative findings in this patient, she did not have any pallor, and there was no guarding. Okay, this will suggest unlikely to be an acute inflammatory condition. The liver, spleen, and especially the gallbladder was not palpable. Okay, and there were no other masses, especially in the epigastric region. So with this the findings, the possible diagnosis, what are they? Okay, now we have got more information. 41-year-old female patient with 1 week history of jaundice and fever, and now she has confirmed to be having fever and mild tenderness in the right hypochondrium. Likely causes will be common bile duct stone, choledocholithiasis, with obstructive jaundice, ascending cholangitis, bile duct stricture, and acute pancreatitis. Okay, these are the 4 likely causes that we can entertain after analyzing the history and the physical findings. So after we have come to a clinical diagnosis or clinical problem. What is the clinical problem of this patient? Is the patient with obstructive jaundice and ascending cholangitis. Okay, that is the problem. Now we have to find out what causes this problem. That is, what's the diagnosis of these problems. The provisional diagnosis, as we have already entertained, is a choledocholithiasis with obstructive jaundice and complicated with ascending cholangitis. So differential diagnosis will be bile duct strictures, carcinoma head of pancreas, cholangiocarcinoma, and periampullary carcinoma. These 3 are unlikely to be the cause because of the patient is a young patient and the history is very short. So your question number 1, what are your differential diagnoses? Okay, these are the differential diagnoses we have mentioned. Of course, we also add in cholestatic jaundice due to the oral contraceptive. Okay, so name the investigations for the patient. So the patients, we do a routine investigation as baseline, and in particular we do a full blood picture looking especially for leukocytosis. Renal function, look for evidence of renal failure because of hepatorenal syndrome. Urine analysis and serum amylase, just in case it is acute pancreatitis. Liver function test is a very essential investigation for this patient. And we look into the bilirubin, especially the conjugated and unconjugated bilirubin levels, which will give us an idea of the nature of jaundice. Serum alkaline phosphatase also will be markedly raised in patients with obstructive jaundice. Then the liver enzyme AST and ALT is also important, which may indicate whether there's some form of hepatitis is the cause of the problem. And of course, albumin is important to know the liver function. So patient with jaundice, coagulation profile is very important. So we must do a prothrombin time, clotting and bleeding time as well. In the imaging investigations, the most and the preliminary investigation will be an ultrasound scan, which will give you the nature of the gallbladder, presence of gallstones, the dilatation of the bile ducts, especially the common bile duct and intrabiliary ducts, and at the same time, in a small percentage of patients, the possibility of stone can also be detected in the common bile duct on ultrasound. Ultrasound will also help you to look at the liver to see if there are any other foci of infection or tumors or cirrhosis. And the other one is whether the pancreatic head is bulky or there's a mass lesion there, to look at that. So ultrasound scan, although not the best, will help to determine all these conditions. As the patient is jaundice, and depending on ultrasound, if the ultrasound does not show any mass lesions, then we straight away go for an ERCP for this patient. And ERCP will determine the cause of the biliary obstruction, whether it is a stone or a tumor. And whether the CT scan is necessary will depend on ERCP. Because if it is a stone, then ERCP sphincterectomy can be done to remove the stone. Okay, this is an ultrasound of the patient with the CPD which is dilated, which is more than 6 millimeters in diameter, and the stones in the lower end of the CBD. It can also help you, ultrasound, to see whether there's any mass lesion in the head of the pancreas here or in the liver. So the next question is, ultrasound done showed a stone in the lower end of the CBD. What other features will you look for? Just said the other features will be dilatation of the CBD, dilatation of the bile ducts, and also mass lesions in the liver or spleen. And this, just for your information, this is an ERCP picture. It shows filling defects in 3 levels. One here at the ampulla, one in the lower CBD, and another one also in the lower CBD. So these are filling defects which indicate the presence of stone in the lower end of the CBD as the cause of obstruction. And you can see here the common bile duct is massively dilated right until the porta hepatis. The intrahepatic ducts appear to be normal. So the final diagnosis from this patient from history, physical examination and investigation is cholangitis with obstructive jaundice and ascending cholangitis. With this diagnosis, then we have to entertain or go into the subsequent management of this patient. Management of this patient, starts with resuscitation. IV fluids and electrolyte balance must be ensured. Antibiotics, broad spectrum antibiotics with metronidazole must be instituted for the patient. Correction of coagulation disturbances are important with the injection vitamin K regime. And when these 3 conditions are met and the patient is more stabilized, then you have to think of a definitive treatment to either how to remove the stone. The best and the easiest method these days will be a ERCP with sphincterectomy and extraction of the stone. And at times you may want to put a biliary stent. Laparoscopic cholecystectomy may also be done at the same time if the patient is stable. Otherwise, it has to be postponed to a slightly later date. If for some reason ERCP is not available, you may have to explore open exploration of the CBD and removal of the stones plus placement of the tube. Okay, this is very important because you cannot wait too long for the patient because patient may go into septicemia. Okay, next question 5. What is Charcoalstriat and what is the Prognosis law? Okay, Charcoalstriat is a triad consisting of jaundice, pain, hypochondrium, and fever. And this fever is classically associated with chills and dry coughs. These three together is known as Charcoalstriat, which is a diagnostic feature of cholangitis. Okay, patients with cholangitis may have all these symptoms or may have at least one of these symptoms. And I must emphasize here, these three symptoms are usually intermittent in nature. They come and go, okay, until they can develop sepsis. Prognosis law states that in the presence of jaundice, an enlarged gallbladder is unlikely be due to gallstones. This may be explained by the observation that gallbladder with stone is usually chronically fibrous and incapable of enlargement. Okay, so in this patient, the gallbladder is not palpable. Therefore, it is unlikely due to a tumor. It is more likely due to be gallstone obstruction. Having discussed the clinical case scenario of this patient with ascending cholangitis, I shall now go into some salient points about ascending cholangitis, cholelithiasis with ascending cholangitis. To understand that, this is a picture showing you actually what cholangitis is. Cholangitis is inflammation of the bile duct, from bile duct, common bile duct, right until into the intrahepatic ducts. So the whole ducts can be inflamed. And number of causes, of course, most of the time is stasis due to obstruction at the lower end. And the most common obstruction is due to gallstone. So inflammation of the bile ducts is known as cholangitis. Now I shall discuss briefly the topic of cholangitis. Okay, cholangitis refers to infection of the biliary tract, as I showed you earlier, and it's associated with high mortality and morbidity if left untreated. And therefore, it is an important condition to recognize and manage aggressively and with some urgency. Cholangitis is caused by a combination of biliary outflow obstruction, that means there's obstruction of bile in the ducts, superimposed with biliary infection. During the obstruction of stasis of bile combined with an elevated intraluminal pressure in the biliary system allows the bacterial colonization of the biliary tree to become pathological. The causes of cholangitis: any condition which causes occlusion or obstruction of the biliary tree has the potential to cause cholangitis. Okay. However, the most common causes are gallstones and ERCP, which is iatrogenic. Okay. Other less important causes are cholangiocarcinoma, acute pancreatitis, primary sclerosing cholangitis, ischemic cholangiopathy, and parasitic infections, which are rather rare these days. So the most important cause will be gallstones and ERCP. ERCP involves the instrumentation and also laparoscopic cholecystectomy or any operations on the biliary system may give rise to cholangitis. The most common infective organisms implicated in cholangitis are Escherichia coli or E. coli, which accounts for about 27% of the infections, followed by Klebsiella species and Enterococcus. These are all E gram-negative organisms. There are also anaerobes that are involved, of which the most common is bacteroides. Now we come to the clinical features of cholangitis. This is basically consists of the Charcoalstriat of right upper quadrant pain, fever with chills, and jaundice. The jaundice is usually moderate to severe with bilirubin exceeding more than 50 micromoles per liter, and it is of the obstructive type with the conjugated bilirubin much more than the unconjugated bilirubin. Obstructive symptoms like itchiness, pale stools, and dark urine are other common features of this problem. Usually, there may be an history of gallstones, recent biliary tract instrumentation such as ERCP or cholecystectomy, or previous history of cholangitis. So this must be carefully elicited from the patient's past medical illness. Medications including oral contraceptive pills and fibrates can increase the risk, of cholangitis. On examination, patients may have fever, pyrexia in almost 90% of cases, and this fever is associated usually with rigors, chills and rigors, jaundice, right hypochondral tenderness, and in severe cases, it can also lead to septicemia with confusion, hypotension, and severe tachycardia. Okay, this patient has got quite a marked tachycardia, but the hypotension is not there. The two common eponymous syndromes associated with cholangitis are Charcoalstriat, the classical triad, and Reynolds Pentat. In Reynolds Pentat, in addition to the three features of Charcoalstriat, there's additional hypotension and mental confusion. Okay, these two last features suggest the patient may be going into septicemia and shock. Okay, these are the summary of the clinical features ascending cholangitis, which consists of the Charcoalstriat and Reynolds Pentat. Okay, the Charcoalstriat consists of the right upper chondral pain, jaundice, fever with chills and rigors. In addition to this, additional hypotension and mental confusion added to this Charcoalstriat is known as Reynolds Pentat, and which is an indication of some form of suppurative cholangitis is taking place, which may be going on to septicemia. Differential diagnosis. Cholangitis is not a complete diagnosis by itself, as there are always some underlying cause behind for this condition, and that should be identified and treated aggressively. These include gallstone disease, especially gallstone at the lower end of the CBD, strictures of the CBD due to previous ERCP or cholecystectomies, acute pancreatitis, and the tumors which we mentioned earlier. Okay, so there must be one of these causes must be identified and treated. The clinical features of cholangitis are very similar to other biliary pathologies, such as biliary colic and acute cholecystitis. In biliary colic, will present with colicky right upper quadrant pain, yet without fever, leukocytosis, or jaundice. Whereas in acute cholecystitis, these features may be present with right hypochondrial pain and fever, yet jaundice may be absent or very minimal. Rarely they are markedly jaundiced. Investigations, the laboratory tests, routine blood tests, which I already mentioned in this patient. FPC will show leukocytosis. LFT will show raised ALP, alkaline phosphatase, and GGT with raised bilirubin. This case that we discussed already demonstrated these signs. And what is important is to do blood culture. It must always be taken in suspected cases, okay, which may be positive in about 20% of cases. This will help us to give the most effective antibiotics against the organism that is being isolated. Next, we come to investigation is an imaging. Ultrasound scan of the biliary tract will show bile duct dilatation. As in this case, it also shows a stone in the lower bile duct. The common bile duct is normally less than 6 millimeters in size. The size may vary in older patients or patients with previous surgeries. So any diameter larger than that suggests a dilated bile duct. And then you may have to do a ERCP, which is the gold standard investigation for cholangitis is ERCP. So as long as you suspect cholangitis, features of cholangitis, the most important investigation is ERCP. Of course, it's after the ultrasound. ERCP is both diagnostic and therapeutic in this patient. Some endoscopies may require an MRCP prior to intervention. However, this may not be necessary in all the cases. We can go straight to do an ERCP. Okay, management of the patient. This immediate management. As I mentioned earlier, patients with cholangitis may present with sepsis, so should be managed promptly and often with a high level of care and urgency. First, under the immediate management will be IV access and fluid resuscitation, okay, to ensure the fluid and electrolytes are in balance. Routine blood tests, which I've already mentioned earlier under the case discussion, and blood cultures must be taken early. As soon as the patient comes in, you suspect cholangitis, jaundice patient with fever, you must do a culture so that you can get the results and you can modify your antibiotics according to the culture report. Meanwhile, you must start them on broad spectrum antibiotics therapy, usually to cover the gram-negative organisms such as amaxiclav or broad spectrum cephalosporin plus metronidazole, as these will cover both the gram-negative and anaerobic bacteria. Definitive management will be biliary endoscopic decompression. This is the ERCP. And this must be done as an emergency intervention. And in many cases, if you do it early, it can save life. ERCP with or without sphincterotomy and stenting should clear any obstruction. This is the treatment of choice for all patients. In patients who may be too sick to tolerate ERCP, percutaneous transhepatic cholangiography or PTC can be used as a second line of intervention. But this investigation is becoming not so useful design because ERCP is far superior to it. In the long-term, patients may require cholecystectomy if gallstones are the underlying cause. This can be done with the ERCP if the patient is clinically stable and fit for the procedure, or it can be done as a elective procedure weeks later when the patient is more stable and his biliary tree has been decompressed adequately. Okay, the laparoscopic cholecystectomy will be the operation of choice. ERCP, must remember, has got some significant complications as well. Okay, significant complication of ERCP including repeated cholangitis. You can reintroduce bacteria to cause repeat cholangitis. can cause pancreatitis in about 3 to 5% of patients. Bleeding, okay, especially when the sphincterectomy is done, higher chance of bleeding, and perforation of the bile duct, which is a rare complication, yet must be kept in mind, especially for urgent surgical intervention is required. What's the prognosis of cholangitis? The mortality of cholangitis is around 5 to 10%, which is a significant figure. And this is so in those patients who we have given adequate antibiotic therapy. Okay, but the therapy was started late. Early ERCP and early antibiotic therapy have both been found to improve the patient outcome, the prognosis. Factors which increase the mortality rate include delayed diagnosis. Very important. It's very important to diagnose early. Delayed diagnosis, comorbid illnesses like liver failure, cirrhosis of the liver, chronic kidney disease, hypotension, female patients, and those above 50 years of age, and more so patients with diabetes mellitus. These are all high-risk patients, and these patients, if the treatment is not started early and adequately, then the mortality rate among them may be high. Having said all this, now I come to give you the key points or summary of cholangitis. These are the following summary of the cholangitis. Cholangitis is most commonly caused by gallstone disease and is associated with high mortality. Patients will often present with right upper quadrant pain, jaundice, and fever, the so-called Charcoalstriat. Most cases should be initially investigated via ultrasound. Okay, in fact, all patients should be investigated by ultrasound these days. All right. Early IV antibiotic therapy is warranted, yet definitive treatment often comes via ERCP, which is done as soon as possible. As soon as the patient is fit for the procedures, it should be done within the first 48 to 72 hours. Okay, so these four are the take-home key points about cholangitis, which was clearly demonstrated by this patient, 41-year-old patient that we discussed just now. The following is a short video by Jürgen Paul of Horst Schmidt Clinic in Germany. It is on choledocholitis, sphincterotomy, and stone removal with an extraction balloon.
This is an ERCP in a 72-year-old man with symptomatic choledocholithiasis.
This brings to an end the first case scenario on cholangitis. I hope my discussion on this topic will be of use to you in understanding the topic better. Till I see you again in the next case scenario, thank you.